So cost is a big barrier. You know, for some of our patients, it makes the difference in whether they're going to take the medication or not. Particularly if they're in a lower tier for the copayment, for example. It's not unusual for copayments to be up to $50 in the lower tier in the formularies. So for many patients, particularly if they're on many other medications already, that could be enough of a difference about whether they actually would take their medication. And increasingly, doctors are on the hook too, because in the global payment plans that many doctors are participating in, we get a fixed payment for each patient per month, and if we use expensive medicines, that can come out of our own budget as well. I think if a novel drug offers a clear advantage and is unquestionably better for the patient in terms of efficacy and safety, that may be a cost that would be acceptable to bear for us, and then potentially for the patient if they can afford it. In instances where there's no substantial benefit of the newer drug compared with the older ones, let's say it's equally effective and safe, I think cost should be a major driver, and in that instance it should not be a first-line therapy. In either case, we need to be open with our patients and let them know that this is a factor, and find out before writing the prescription if that would prevent them from safely and correctly taking their medication. So sometimes, depending on financial resources and the need, there may be programs where certain pharmaceutical companies can provide medication on a compassionate use basis to the patient, even if they can't afford it. That does require jumping through a lot of hoops to get that done. In large academic practices like mine, I have a resource specialist who can help with that. In smaller independent private practices, that could be a significant amount of effort required.